Good morning and welcome to my YouTube channel, Pain Free Partner. Today I'm going to talk about adductor canal block and catheter replacement. So, what is the significance of it? Welcome to my channel and welcome to our institute, Mahatma Gandhi Medical College and Research Institute, Sri Balaji Vidyapeeth, Pondicherry, India. So, a method of continuous catheterization or whatever it is, continuous nerve block catheter was introduced long back in 1946 for brachial plexus block. Now, I have used in long time back, 30 years, 25 years back, by putting a small venflon and using the paresthesia technique. Those are the days where there is no ultrasound. So then after that 1 millimeter, just the cannula is inside and keep it like that. To top up with lignocaine adrenaline every 2 to 3 hours. Why do we need catheters? If the analgesia requirement is more than 24 hours. Better post-op analgesia, less opioids, less better outcomes, and less rebound pain. This I will take later. As soon as the nerve plexus block recedes, the pain comes back. That is what is called the rebound pain. That is less with catheters. Only transit from acute to chronic pain is also less. But the problem is, if there is any ongoing ischemia distally, the pain relief will mask that. The cost, technical knowledge, catheter malposition. This is very important. Malposition of the catheters. It comes out slightly, it goes in slightly. All these are the problems with failures. What are the available nerve block catheters? Femoral, sciatic, brachial plexus, intercostal, ilioinguinal, iliohypogastric, peroneal, so many things. You can see. Now we will go into adductor targeting the saphenous. Even if you don't believe, somebody has put lesser palatine nerve block catheters. Now the intercostal nerve block catheters. Now you see, if you put a catheter here, it is not needed that it should go here and it should go here. It is not needed, necessary. It may be here only, and we are not seeing the nerves. See, for example, in costoclavicular space, this is subclavius serratus anterior intercostal, where you insert the catheter, this is brachial plexus, but still there would be some muscle loss or paralysis. It is very difficult to mobilize even with 0.15% bupivacaine. So the most painful surgeries, one of the most painful surgeries is total knee arthroplasty and sometimes some arthroscopies. So we need to block the saphenous nerve. Sometimes patients' plan was to do bilateral TKR. The first TKR it is done, the painful is he will not get operated the other side. So good pain relief after TKR is a must. Total knee replacement. The saphenous is a branch of posterior division of the femoral nerve. Here it comes like this, and it accompanies the femoral artery within the femoral canal and goes femoral triangle and goes into the adductor canal. The most important thing and gives up the infrapatellar branches, goes on to the saphenous nerve to give sensory branches to the medial side of the ankle. Now you can see here, there is some transit at one place. The medial femoral vein becomes lateral. This becomes slightly medial. Now you think of this when we talk later. So this is the femoral triangle. This is the sartorius muscle and this is the adductor magnus. So this is the femoral triangle and it goes on into form the adductor canal. This is the green one and this is the adductor hiatus. Now you can see the adductor and the sartorius meet at a place. This is where the femoral triangle ends. If you are supposed to give a block somewhere here targeting the saphenous or femoral, it is likely to go up and paralyze your quadriceps muscles. So this will cause weakness or problems in mobilizing postoperatively. So if we give distal to this here, we are less likely to paralyze the quadriceps. Now the femoral triangle ends. This is the other side. Now you can see this is the sartorius, this is the adductor, this is the femoral nerve, in the vein arteries are there. Now if you keep in the mid of the thigh like this, now you can see this is adductor longus, sartorius getting end like this. This is the place where this Now it is not needed that you have a 15 lakh machine. This is a 4 lakhs machine. Yes, we can see the adductor longus, femoral artery, femoral vein, sartorius. This is the place where the femoral triangle ends. Then starts your adductor canal. Now the saphenous nerve can be blocked by perifemoral here, subsartorial in the femoral, subsartorial at the proximal adductor. We can block it here. We can block it near the saphenous vein or in the ankle. Now, what are our plans in the proximal adductor canal? Possibly blocking the saphenous and possibly blocking the nerve to vastus medialis, which has got extensive nociception into the medial side of knee. Then after that you come, now you see the femoral triangle ends. Now after that you just come little down, you will see the veil. Adductor longus, the vastus medialis is slowly appearing and this veil appearance. Now then slightly go down and laterally, you will see the adductors, sartorius. This is the sartorius membrane. This is the vasto-adductor membrane. This between vastus medialis and adductor. This is the vastus medialis. This is the adductor canal. Femoral artery, femoral vein, saphenous nerve, and sometimes nerve vastus medialis, sometimes a few branches of obturator nerve. So come down and go laterally. Why not go down further? Distance, I have already told. The vein goes laterally, the nerve comes medially, the distance opens. Now you can see here. This is a normal place where you can have a nerve. This is the vasto-adductor membrane, vastus medialis and adductor longus, sartorius. Now this vasto-adductor membrane, here you can see the saphenous nerve. If you go down further, it will be saphenous nerve will be here, and the vein will come here, and the nerve to vastus medialis distance will be very high. No nerve targets, but still you can go down, and surround the artery with 40 ml of local anesthetics. Possibly it may go to the sciatic, and this you may call as 4-in-1 block, 4-in-1 block, but it is likely to have definitely a motor component. Indications: foot ankle surgery, anesthesia with sciatic. Sometimes pain relief in knee. Sometimes saphenous vein harvesting and stripping. Now you can see this is the femoral artery, this is the sartorius muscle, and the needle is coming from lateral to medial. Now you can see the video. Now we are giving the drug, and then I'm trying to pierce popping the vasto-adductor membrane here. Pop is there, and then you can see the nerve to vastus medialis here. And now I have not still popped. Yes, that's the pop. Now we give the drug. This is what is the saphenous nerve. The nerve to vastus medialis and saphenous are separate. The needle is coming very nicely. Okay, the saphenous is very clearly seen. There may be equipment, usually anything, needle over catheter or needle inside the catheter. But what I use is routinely is a very cheap. You don't need these LOR syringes, all these things. ETO needle and a simple catheter is around 250 rupees. Now, actually, what we need to check, all the three things are okay. Three tips flowing freely, and just everything has to be flushed, no air inside. And also flush the needle, epidural needle with water, connect a PMO line, connect fully flush, because there should not be any air. Now you see, insertion of epidural needle should be from here, very flat, because this is the place where sartorius, vastus medialis, saphenous nerve, femoral artery. Now, just the slope should be like this. If you have slope like this, you cannot pierce the vasto-adductor membrane and give it to the saphenous. Now, bridge the vein. That is very important. Some people keep this thing like this. Now you can see here, this is the saphenous nerve, femoral artery, sartorius, vastus. What we need to do is we have to keep one at least behind the vasto-adductor membrane, one or two behind and one here. So that is what the catheter should be placed for a successful adductor canal block. It is very difficult, but there are certain easy techniques. Now don't push the catheter much like an epidural. because already we are inside the thing. Epidural tip is inside. Now, if you put 1 centimeter, it is enough. If you put 5 centimeters, it is go around the femoral artery and get somewhere else. So, second operator is needed if needed. Now you see the video. I am getting the epidural needle here.
Beautiful. Now you can see this thing pushing, and also there is an expansion of the vastus medialis and sartorius. There is an expansion there, and also there is this thing. Good. So there is an expansion here and also an expansion here. This is the vasoadductor membrane which is breached, an expansion here to target vastus medialis and the saphenous nerve.
We can use Ioban for water-free tight dressing. Tincture benzoin can be used, but preferably don't tunnel because tunneling, the practice of tunneling will slightly move the catheter. So it is, the problem is fixation is there, but you have to keep like this, put a tincture benzoin and keep an Ioban. So don't prefer air test. The needle is coming here, and if you give air, everything will be gone. We can prefer an out of plane single shot block here if you are having only single shot. But if you are going to have a catheter, it should come in this plane, breach the VAM, one hole here or one or two holes here. It is not needed every time we should have in plane for all catheters. For example, if you are going sciatic nerve, this is the paraneurium. Pierce the paraneurium and you can insert more. It is not needed that it should be 1 centimeter. There is something called eye-safe approach, interfacial plane between sartorius muscle and femoral artery, eye-safe. But the problem is the saphenous nerve is here, the nerve to vastus medialis is somewhere here. Where is the tip of the catheter? So you have to give large volume to encircle this, and that is not needed. What is the dose after catheter? 15 to 20 ml of 0.2% bupivacaine or 0.15% bupivacaine every 8 hours. Or sometimes we may need to have an infusion of 6 ml of 0.15% or 0.2% ropivacaine. Chrononin, dexmet, opioids, pregabalin, dexamethasone, all are reported, but it is not needed to have an infusions or catheters, top-ups, and have adjuvants. Here they say that femoral triangle proximal or maybe same, but here in this study, they have added local infiltration anesthesia, which is not accepted by many of our surgeons. Who should receive an outpatient if the patient is fine? If an attender is fine, he receives phone calls, put a catheter, do a total knee replacement. Next day morning you discharge and give them how to give these top-ups or anaelastogenic infusions. Some complications of these bags. The most important complication is failed nerve block because the catheter has come out slight or gone in. This intravascular systemic nerve injury infections are rare. Saphenous catheters or adductor canal catheters are not the end because we have this targeted here. There may be targets here. What I want to tell is if you breach and above give vasoadductor, it will go subsartorially. Slightly it will go subsartorially. So the possible nerve, that medial reticular nerve may be blocked. But one thing very important is the lateral side is not completely blocked. So we may need to give some tramadol or 15 because complete deafferentation may be there. The patient may not be having any pain, but you not have slept. This is what is important here. Subsartorial plexus block is given here. But you want to have breach this, give here and give there, then you are even 10 ml here may go like this. Okay, so certain divisions of the operator, certain divisions of the medial reticular nerve will be blocked by this technique. So saphenous nerve as a proximal adductor canal is ideal because motor sparing is there. The nerve to vastus medialis and saphenous nerve are close. TKR is the most painful surgery. Go just below mid-thigh, get the whale sign, go laterally, get the vastus. Then go in the angle where the vastus medialis and the sartorius is there. Catheter holes keep in this side. Don't insert the catheter too much. If you want to give paracetamol, beware of ischemia awareness in any catheters. Thank you very much.